So first about me, I'm a health economist. I chair a section on health economics at VU University in Amsterdam. It's a group of about 20 people in health economics. Usually, like in the past, I used to combine public health, epidemiology, and economics, whereas now the majority of my group is working in healthcare. I've been involved in advising government and politicians, especially from all parties. Left to right, center to extremist parties almost, in their so trying to grapple with the political issues and concerns dealing with the policy making, and rather than going through the actual situation in the Netherlands, I'm going to explain how we got here. So I'm actually going to go back and look back at the first couple of months when the essential policy decisions were made that are still essential to understanding what's going on in the Netherlands. Right. So I think, and my background is in health economics, which is, as I mentioned before, a combination of public health and economics, and in the middle is where you'll find healthcare. So those are the topics we deal with, we combine different fields, and that makes it easy for us to understand the scientific literature, especially based on epidemiology. I think virology is more difficult for most health economists. Certainly for me, that would be the case. So most of what I'll tell you is what I know from the literature in epidemiology, and I'll try and relate that to economics. Right. So we don't know very much about virology, and also because we do combine economics and health, but we're not like macroeconomists. And in fact, now that turned out to be quite important, but we don't know very much about macroeconomics. So I had to borrow quite a bit from my colleagues there. So going back to February 2020, the coronavirus arrived, and for health economists, the question was, what policy could reduce societal welfare loss, if any policy? And to look at that issue, we looked at outcomes, so both in terms of health and economy. So there are other outcomes, right? This affects all parts of life, all walks of life, and all groups, and so health economists merely focus on what are the health and the consequences for health and the economy. And when we talk about health, we typically think about mortality, but we also talk about morbidity and the quality of life. So how much quality of life years are lost because of, I don't know, what the different policies that you could choose between. But also we focus on the distribution. Who actually loses out? So are there particular groups involved? For example, the lower socioeconomic classes, or specific ethnic groups, or people that have particular jobs. So all of that is where we focus on the health side, and on the economy side, we typically look at what are the costs involved in the different policies. So those could be costs related to the healthcare interventions, public health especially, but also more largely, what are the consequences on GDP and income per capita. So going back, not knowing very much about disease X, or in this case, the coronavirus, we typically look at three policy options. And the first is to allow the virus to roam free, or what others have mentioned, have referred to as the let it rip option. And it's especially interesting as an alternative, or as a policy option, when the health costs are low, so there's the health consequences are minor, and the economic intervention costs would be very high. And in fact, I think you can relate to, for example, the seasonal yearly flu, and say, well, the costs are sometimes not quite low, but they could be substantial, but they were typically not as important to allow for the large economic damages that would occur once we try to stop a flu from, let's say, ripping through society. So typically, allow the virus to roam free is what we also refer to as the flu policy. Yeah, and the end of such a policy would coincide when there's herd immunity, and the virus just like tapers off, to disappear, like not too many people, like the number of people that get infected tapers off, and at some point the disease no longer influences the average health state in the Netherlands. Typically, given our climate, that's what we see with a flu happening at around March, April. The mitigation, flatten the curve, is the second one, and it involves trying to make sure that if there's a wave of new people get infected and they might need or require healthcare, especially when they require intensive healthcare like ICU care, then at that point what we want to make sure is that health system doesn't get overrun, and health system can still treat other patients, and we can still provide like appropriate healthcare to all the people with the virus. And so we would flatten the curve, but we would allow the virus to pass through. The consequence of that would be that herd immunity would take for a much longer time, and we had anticipated around about March that it would take about 2 years' time to allow the virus to spread through society in a controlled fashion. And the third option was to try and contain the virus, something that we typically see with SARS-1 and MERS, other policies, which means that we try to identify, find the people who are infected, isolate them, quarantine all the people that have been in touch with them, and try and eliminate the virus, at least locally. So it's impossible to eradicate the virus worldwide, but you could eliminate it locally and then have some border control and so on. And of course, those are the three options. But the question is, which of the three is most appropriate to deal with this virus, and how do we typically go about? So, what is our way of trying to differentiate between the different policies? And this graph to health economists is really important whenever we have a new disease, a new a virus infection that we don't know very much about. And so on this vertical axis, you'll find the case fatality rate, which means the number of people that have been tested positive, so the share of people that have been tested positive that die. And obviously the maximum is 100%, so each person who got the disease then dies. But for diseases like MERS, that would be approaching 40% of the people who died. And for Ebola, it could be, I think, slightly 50, and bird flu could even be slightly higher. So those are diseases that once you get infected, your prognosis looks pretty bleak. And so those diseases have such dramatic health consequences that it's much more likely for a government to try and intervene and try and stop the spreading of the disease. Now, on the horizontal axis, you'll find a reproduction number, which means, on average, if one person is infected, how many other people will this person infect when there is no immunity in society? Which is to say, what is the, so if this number is above 1, you will see a rapid or an increase in the spread of the virus, and if the number is below 1, you will see that the virus by itself will stop spreading. Now, if it's more infectious, you will end up on the right-hand side of this scale, which is to say that if the reproduction number is higher, it's more difficult to stop the spread of the virus. The economic costs of trying to stop the spread is also higher, and I think that's something that we're currently observing with the new English variant, the British variant B.1.1.7. Now it's more contagious, and as it is more contagious, we need to come up with extra interventions to try and stop the further spreading of the disease. So as we move to the right, the economic costs increase. As we move to the top, the health consequences increase. And now we are going back to March, to February, March. We were trying to estimate, where is this new virus? Where is it located? And you can see the pink rectangle. And this is the area where we thought, well, it's going to be somewhat here. Now we know because of the British variant is probably more to the right, but in the first couple of months we thought this is probably where it is. And then, you know, it's not quite as lethal as other diseases have been, like for example SARS-1 you can find here, and it could easily spread. It could be around about here. So it was, I have to say, at that point it wasn't immediately clear for the governments what to do, and so the Taiwan government and the government of South Korea and Australia and New Zealand, they certainly the people from Taiwan, they sent in people to Wuhan to study the situation over there and not just look at the figures. And they came back and they said, well, certainly, given the characteristics of this virus and the consequences, we need to stop it in its footstep. And so they decided to go to group SARS-2 with diseases like on the left-hand top, on the top left of the graph, whereas some other governments like England, Sweden, and the Netherlands looked at it and decided it was more like a flu. And I have to say it's somewhere in the middle. Clearly, at the beginning it wasn't immediately clear. And so as a consequence, the language of flu was the language of politicians and policy advisors in both England, the Netherlands, and Sweden alike. And right now, I have to say, well, before I continue, I should say, all of these viruses. I mean, we're trying to capture this on two axes, and in real life. These characteristics of these viruses are richer. There's more complexity to trying to categorize a virus. And in this case, I think what was particularly detrimental for the policy decisions with respect to COVID was that a large share of the people infected other people before the symptoms occurred. So they were able, I think, something like 40 to 45, 50% of the spread of the virus could be attributed to people who didn't have clear symptoms. And that really made trying to contain the virus much, much more difficult than it would have otherwise been. Right. Now, still thinking about this decision, which direction to go to, we tried to look at what were the maximum health cost of, say, no intervention. What would be the consequence of no intervention, and what would be the maximum economic cost, and try and find out if there's a range and which of the two is most important. So first we started off looking at the Dutch range for health cost, and at the beginning we worked with a slightly higher infection fatality rate. So that is the share of the people that get infected. It's not necessarily the people that have a positive test, right? This is more general, the infection fatality rate. And we assumed in the beginning it was slightly above 1, but even in March, as we got more information and better understand how to deal with it over time, we saw that the best estimated infection fatality rate for the Netherlands was dropping over a number of months to about 1% of the people who got infected. And that's slightly higher than worldwide. And that's because we've got a slightly older population, a larger share of the population is frail. But it was dropping over time as the treatments improved, and we were better able to prevent people from getting to the ICU, and if they got to the ICU, from dying. Good. Given, assuming that the R0 was about 2.5, then if we were able to get rid of 60% of the infections, then at that point we would reach an R effective of about 1, which means that the disease would no longer grow and the infections would no longer grow. It would at some point die out. So we've assumed herd immunity at about 60%. Now, I should say that the attack rate is probably much, much higher because of overshoot if you weren't to do anything. But let's assume that we had a very efficient policy and that all of these people are homogeneous in their probability of infecting other people, and then 60% is about the most efficient rate that you can come up with. Now, we saw that people died in, for example, New York and in other places where a large chunk of the population got infected. We saw that people died at the age of about 75 on average, and in the Netherlands that would give you a life expectancy of slightly more than 12 years. Working our way to the quality adjusted life years lost, so compensating for the quality of life, these people had slightly lower than average life expectancy because they were more vulnerable, more frail, and they also had a slightly lower quality of life, and therefore the number of quality adjusted life years is estimated at about 6 to 9 years, 9 years maximum. So putting all of that into one computation, we can try and work out with our population of 17.3 million people, with an infection fatality rate of about 1% of the people who died, being slightly optimistic here, perhaps with the herd immunity of 60%, and assuming no overshoot, and working with 9 QALYs lost on average, we end up with a QALYs lost. So if we just allowed the virus to let it rip, go through society, stimulate people, or perhaps assuming that people would not adjust their behavior, then we would end up with a QALYs loss of slightly less than 1 million QALYs lost. And that's quite substantial, more substantial than any disaster we've had in the last year, ever since the Second World War. Now, in terms of disasters, it may be very important. If you think about the loss in life expectancy, is actually not that important. That is to say, if assuming that this virus would rip through society once and people would build immunity and would and from that point onwards would not come back and wouldn't harm us every year like a flu would, or perhaps we would find a way to have a vaccine and then stop the disease from harming the health state of the population. Well, in that case, if it's just a once-off, then for the cohort that's living right now, it would mean a loss in life expectancy of 1 month. And that is a lot less, for example, than smoking would be, or cancer, or stroke and heart disease. And so for cancer, you could think about 3 years, 2 to 3 years in loss of life expectancy. So this disease, compared to other major diseases, is relatively minor for health economists. So multiplying the QALYs lost of doing nothing times the value of a QALY. So health economists value health quality adjusted life years at about 40,000 euros per quality adjusted life year lost. If you were to multiply that, we would end up at 37 billion euros lost. So why do we value health in this way? It allows us to make trade-offs between, for example, the economy or education and health. So it's to support policymakers who have to make these terrible and difficult decisions to try and come up with some sort of an intuition with respect to how to weigh the different outcomes of different policies. Going to economic costs. So focusing on the economic side of things, we can look at the expenditure. So when we try to try and stop the spread of the disease, that would result in quite an intensive policy on the public health side of things, and that would cost something like 5 to 10 billion euros. We can also look at health care costs. Those are going to be relatively minor, like I've estimated them at 5 billion, but they could have been much less. It's because providing healthcare to the COVID patients is actually leads to less healthcare for other patients, and that balances out more or less in most of the countries. Now, because of the arrangements that have been made in the Netherlands in the Dutch situation, we actually spend extra to hospitals rather than try and force them to balance out their yearly revenue and now spend it on COVID patients. So I estimate this here at about 5 billion euros. Productivity loss is also comparatively minor. That is because the people who will actually lose productivity or lose their health over the COVID virus typically are the ones that aren't are participating in a lower degree than the people who survive the disease without all too much loss in health. So it's the vulnerable population that loses most of their health and their life years, quality adjusted life years that they would have otherwise had, but those people typically contribute less to the productivity of the economy, as they are quite often the pensioners, for example, or they are for other reasons not participating in the labor market. Looking at all of these figures, those are substantial, but the economic crisis of 2020 was much more substantial. And I think just looking at the scale of things here, the economic crisis was actually much more expensive than all the healthcare costs, and should have actually been at the core of policy making. We should have tried and come up with policies to reduce the economic crisis and perhaps not worry as much about healthcare costs. Now, looking at the range of the health losses valued in euros, you can see that they range between 5 and 37 billion, and that 37 billion is the worst of all states almost. And then range of the economic losses is something between 62 and 100 billion, and that's extrapolated to also include not just 2020, but also the consequences in later years. Now, my conclusion, and I think the general conclusion of economists, is that economic costs are far higher than health costs. Or another way of saying this is, when it comes down to societal welfare, the damage to societal welfare in the general way of looking at this, where both health and economy participate, like part of this larger concept of societal welfare, then the economic damages could potentially be much more important, much more significant than the health costs. And therefore, perhaps taking into account the economic consequences in policy making should, I think economists would argue, should be more important, or at least equally important, as focusing on the health state. Now, having said that, so at the societal level, we can say if we were to come up with all sorts of policies and try and minimize the health state and really spend a tremendous amount of money, both in public health, in healthcare, and in through the locking down of the economy, in economic damages, would you say that the cure of all of those policies together is worse than the disease? Then sure, at societal level, that would be the case. At individual level, that's quite different. It depends on who you are. Most of the people that have a low risk would probably argue that from their perspective, continuing life as they had in the past is preferable above all of the policies that have come into place since. But about 25% of the people in the Netherlands have been categorized as high risk, and those people would feel very different about this, of course. So it depends on who you are, whether you think that the policies, given your health stage and your risk, whether the policies are in your favor or not. And of course, there is something more, and that is that, for example, I'm not part of the high risk group, but I would really, really like to prevent spreading the disease to someone I care about, or people that I don't know that are part of the high-risk group. I don't want to contribute to spreading the disease, so I would too, even though it's not my looking just at me personally, given my risks and benefits. I'm not particularly scared of getting the disease, but I would be scared, and I was scared about spreading it to other people. So yes, it depends a lot on your personal preferences and your personal situation. Okay. So what matters most? You could say, well, I mean, if we are to rule this world, this society, if we've got total control over what people do, and we're looking at the consequences at the societal level, one of the things we could decide is say, well, this is terrible that this is going to happen to us, but it's in the interest of society at large to not do anything about it. That's one way of looking at it, and certainly I think that is a way that some countries have gone. For example, Brazil and some of the states in the US, and the Republican-led states in the US have come to that conclusion. Now, I think it's more difficult. I think there's more to this than this very simple layer of just looking at what are the most important consequences, and by just looking at individual behavior. And so we're looking at two states. That's Minnesota and South Dakota. Minnesota in dark blue, and as you can see, as 15 March came and passed, there was a big scare in society, and the spread of the COVID had captured the minds and the discussion in the public in both states, both in Minnesota and South Dakota. Now, one of the two states came with a lockdown, and the other one decided to stay open, right? So the people had the opportunity to go about their daily business as they would otherwise do, and now it's up to you to see. Can you see, like, so one of the two states decided to close the school, have a lockdown, the other one didn't. Which is which? Well, you can, first of all, I think you can tell that the differences are minor, and it was South Dakota who, like as a state, didn't impose a lockdown. Now, on the vertical axis, you can see that as the total spending by all consumers decreased quite substantially because of the spread of the virus, about a 30% in like 2 weeks' time, and then it continued to consumers continued to spend at a very low level, and I think we can pretty much agree, and that's the conclusion of most economists who looked into this. We can say, well, the lockdown itself didn't really adjust the behavior of people and the functioning of the economy all that much. It was the virus itself. And so, as you can go back to the discussion, and like, are we like, can we look at this from a societal perspective, or do we allow people to adjust their behavior because we live in a free society and they can make up their own minds about what to do as a consequence of this new risk that's out there? And you can see that people behaved rather similarly in states with and without lockdowns. And that also applied to to Australia. In Australia, we have some more data. We can see that as the virus came in and there was a severe lockdown and there was a scare, people started stopping, they started decreasing their discretionary spending. So the blue line dropped quite substantially when the crisis hit Australia. And then the government wanted to stimulate the economy and came with stimulus packages, hoping that the Australians would start spending more money and would keep the economy going. That didn't really work. What happened was that the majority of the money of the stimulus packages went into the savings accounts. People started saving big time. They were afraid about what was yet to happen. And whatever the government did, they weren't able to get the economy up and running again. So there was a big damage again. About 30% of the spending, discretionary spending here, was just was lost over the spread of the virus. Now, at the end of this graph, you'll find this pinkish area. There is this. It is identified as a period of easing. What happened here is that the Australian government got more control over the spread of the virus, and consumer confidence rebounded. And as a consequence, we saw that many of these savings were starting to get spent, and people were increasing their discretionary spending, even though they were still largely in lockdown. So what we can see here is that economic damages were mostly related to individual behavior as a consequence of the virus.
Well, Dan, Neil here, just to say about 10 minutes left, okay?
Yeah. So we can say that at societal level, the cure is worse than the disease. Individuals think differently. Some of them, quite a few, think differently. And as a consequence, what we see is that because of lack of consumer confidence, we see that the people are spending less, and that is hurting the economy and is also causing most of the damage, economic damage. So perhaps we should not think of this from a societal level as a dictator perhaps would, but think about this as a dynamic society based on like a large group of individuals who make their own decisions, and those decisions could really harm the economy as long as those people are afraid of the virus. And like here on table 1, we see a correlation between the number of people and new cases per capita and in relation or correlated to the daily consumer confidence. And you see here, like in, for example, Italy, you see there is a negative correlation between a higher number of per capita new cases and a drop, or so that would lead to a drop or be associated to a drop in consumer confidence. So there's a very, very direct and very strong correlation. In fact, in economics, we don't usually look at correlations that are as strong as this. I don't think I've seen any policies, any circumstances that would lead to such dramatic differences in consumer confidence or typically any type of behavior. So we also see this in graphs. For example, in Australia, we see a tremendous drop from about consumer index, consumer confidence index that went from about 120 down to 50 as the virus hit the Australian continent, the oceanic continent in Australia. So the way forward for economists then was, okay, perhaps we need to look at this differently. If we want to stimulate the economy, and most of the damages are economic more than health, but if we want to prevent those damages, if we want to stimulate the economy, what we should do perhaps is reduce community spread. So the way forward is to try and stimulate people to regain their confidence, because there is no virus out there, and in fact do what Australia has done. Another alternative is that we could also say, well, so if people are doing things that at a societal level are not in our benefit, perhaps we should try and stimulate people to deal with the information that they've got differently. So for example, we should try and reduce the anxiety that's out there in society, and stimulate people, even though they might be of high risk, or they might, as a consequence, infect their parents who would then die. That would all be perhaps in their personal interest, but it's not in societal interest. So from a societal perspective, what we could do is try and reduce information. And that's pretty much what the Dutch have done. So let's try and stop with the daily information from the Public Health England version in the Netherlands. That's RIVM. Let's try and stop all sorts of anxiety increasing national conferences by politicians. Let's just stress that everyone should go on holidays, and let's give an example of going and enjoying holidays from all policymakers and all like the national policy advisors and so on. So we could try. That's what I'm saying. You could try and stimulate, create an environment, create a situation where people would change their behavior in the direction of what is desirable from a societal perspective. So to not respond to having the virus around as much as they tend to do. Okay, now just looking at excess death. So we're now somewhat further down the road. We can do this for the Netherlands. This has been computed for in the United States, many other countries, and we can find that in the Netherlands, about 15,000 people have died. There's excess death in 2020 over and above what we had expected. And that would be about 135 or 140,000 people. So it's slightly less than a 10% excess mortality rate. And that's one way of measuring the health consequences. That could have been much more, by the way, as I argued before. So that's pretty much how health economists have looked at it. Have looked at it. Okay, there is this maximum health damage, maximum economic damage. What drives the economic damage? Oh, it's individual behavior. Perhaps we should change individual behavior. What are the two ways to do it? Either provide them with a safe environment, or try and have them respond differently to the anxiety or to the having the virus around. As much as they had in the past, and like for example, stressing the fact that it's only high-risk people, people like from high-risk groups who suffer the consequences of the disease. Okay, now once you've made the decision to not go for containment, or go for mitigation, as we have in the Netherlands, or you could go for containment, much like countries like Finland or Norway seem to do, or even Iceland, and you can go further away and look at Thailand and Taiwan and Australia, New Zealand, South Korea. You can make the decision for containment. You can make the decision for mitigation. It would appear now, and it makes sense looking at my presentation, I think, that containment is from an economic perspective, the more viable economic course of action. So it's better for the health state, and it's also better for the economy. But we've made, like, let's just say it, we made the wrong turn, right? Back in March, we chose the wrong path. Now we're on this path. What can we do? What kind of policies have we got to try and optimize mitigation as a policy? And those, I've made a list. There's quite a few studies out there that look at different policies, and what economists would tend to do is try and evaluate both the health consequences and the economic consequences of each of these policies, and then advise the government or allow the politicians to make their to trade off interests of different interest groups that are affected by the different policies, or to trade off different values and optimize the policy based on the opportunities that the alternative policies that are out there. And health economists would have really liked to participate, but haven't really gotten much of a position in this debate. So my conclusion is, it's both a health and an economic crisis, but it's mostly an economic crisis. So most of the societal welfare is lost through the economic consequences, not the health consequences of this disease. 2, the cost of the government interventions are negligible, so they're limited compared to the behavioral change of consumers. So if you want to reduce the economic consequences, you better focus on the behavior of consumers. And consumer confidence appears to be very, very sensitive to the rate of infection. So apparently there is a very strong association between how much confidence consumers have and how much, if they're willing to spend money on discretionary goods, if the rate of infection is low, and they're not willing to spend much if the rate of infection is high. So there is a very, very direct and very strong association. Now, the economic costs the economic costs of the virus infections are in the tens of billions, and public health measures do appear to be very cost effective, both in terms of trying to prevent the health damage and to try and stimulate the economy or boosting the economy. So there is strong evidence, I think, for an expansion of the interventions in the public health arena. And last but not least, I think looking back, it's been a mistake not to involve economics and health economists, especially in the corona policy. So I think had they been involved, we would have perhaps had more discussion about containment and mitigation. And I think economists could have argued in favor of containment, trying to eradicate, to try and eliminate the virus locally, rather than allowing it to spread through society and damage both health and the economy alike. Thank you for your attention.
Thank you very much, Xander. That was fascinating and all very clear as well. We'll have some time right at the end of the afternoon for lots of questions, but there is just one in the chat from Mirko, and I wonder if we might just quickly deal with that one now. The question was, what about the consumption loss, which was when you were talking about the different components of losses, and I think you talked about productivity loss. Yeah. And then also, what about the rebounce effect? People get too cool, cases go up, people become more anxious than before. Is there anything you'd like to just say now in response to that?
So no, I'm trying to make sure that I understand the question exactly. So I think the productivity loss is what we identify as people not being able, because of the disease, to continue working. So let's assume that we allow the virus to rip through society. People will get infected, and at some point will have to work at home if they have minor consequences, or perhaps lay in bed and miss out on working days. Typically, the working part of society doesn't suffer as much from corona, from this virus, as the people who aren't working or aren't unable to work. So that's why the total loss in productivity is actually considered relatively low. Is that an answer, or? I hope so.
Okay, thanks very much. I think we might just move on to the second presentation, and for the students participating, do feel free to type in further questions in the chat, and we can address them in the final slot of the afternoon. But I think what I'm going to do now is say thanks very much to Xander for that really excellent presentation, and we'll move on to Sasha, who's also from VU in Amsterdam, who's going to talk about the student well-being dimension from the Caring Universities project. So Sasha, are you able to get your presentation to come up?
Yeah, thank you, Neil. I just have to try and share my presentation.
Sasha, if you need help, just shout. Can I just say, just before you start, Sasha, if people are popping questions up, you're probably hearing the pings. You can turn those pings off if they're annoying anybody. If you go to the cog at the bottom and click on that and notification settings, you can opt to turn off the little message pings.
Let me see.
I mean, if they're not bothering you, Sasha, don't worry about it. But
it's not bothering me that much, so I'll just continue like it is. So can you see the presentation all right?
Yes, I can. Great.
All right, and if I use this little marker, can you see my mouse moving across the screen?
We can, yep.
All right, great. So thank you so much for having me, and thank you, Xander, for that very insightful presentation. And I'm happy to present some of the results of the Caring Universities project. So my name is Sasha Strauss. I'm a mental health psychologist and an assistant professor at Leiden University in clinical psychology. But I work for, well, most of my time at the Vrije Universiteit Amsterdam, where I'm a coordinator of the Caring Universities project. So probably have to undo this and then press the next slide. So I'm not really sure how to go to the next slide here.
So at the bottom you should have an arrow, or you could choose the arrows on your keyboard should move it on as well for you. There you go.
Yeah, that's working. Okay, so the apparently my keyboard isn't working, but if I press the arrows with my mouse, it works. So that's fine. So my presentation today will be about the aim of caring universities. We've conducted a survey last year of June, and I want to present some of the results with you all. And also 2 weeks ago, on the 7th of January, we've conducted yet another survey among our students. And we have some preliminary results, which I also want to share with you. And finally, within the Caring Universities project, we designed and implemented several e-health interventions, and I want to show them with you, talk about what their aim is, and share some results about students that use these interventions and see what the effect is on their mental well-being. Right. So right now in the literature, we see that there's quite a high prevalence of mental health problems in students. This has been the case pre-corona, and what we will see in our results and what we actually thought is the case that only increased during these challenging times. And the Caring University has been brought to life in order to examine and improve student well-being in the Netherlands. It's a Dutch project, and we want to screen, prevent, and treat mental health problems in students. So this project is divided in two large parts. So we have an annual survey. It's an online survey disseminated by Qualtrics, and it's designed to measure mental health problems in students. All the students of the collaborating universities are welcome to join. And like I said before, we are designing and implementing e-health interventions to improve the mental health of our students. So a Caring University is actually the Dutch branch of the WHO World Mental Health International College Student Initiative. So this is a global initiative led by Harvard University, in which the VU Amsterdam participates from 2016 onward. And currently, we have a consortium of 4 Dutch universities. So the universities of Leiden, Utrecht, and Maastricht are also joint forces with the VU Amsterdam. So this World Mental Health International College Student Initiative is now being conducted in more and more countries worldwide. I believe as of this moment there's 15 different countries involved, with many more colleges involved, and over 40,000 students that have filled out this global survey, and more is to come. Another important goal of this global initiative is the design and the implementation of different e-health interventions globally at different sites that can be used all over the world. So all the things that we are now currently designing and implementing here in the Netherlands, these are under Creative Commons licenses. That means that in the future, everyone is welcome to use the content of those programs. So if they're proven to be quite effective and other members of the global consortium want to use them, they can. And also later on, the results from these projects can be disseminated in low and middle income countries. So the survey is administered online. The main focus is mental well-being of students, and it's quite an in-depth survey. So all different aspects of mental health and related issues are addressed. Honestly, this led to a survey that was a little bit too extensive for students, so it could take up to 40 minutes to fill it out, which is on the long side. This is why they now implemented a skip structure wherein random students get different questions based on a random allocation. This means that the average length of completing the survey is brought down to about 20-25 minutes, and still on a global sample we have the same information as we were to ask all the questions. So within the Caring Universities project, so this is the Dutch project in which the 4 different universities collaborate. We have room to build our own e-health interventions together with a technical company. We do not have infinite amount of resources to spend on this, so of course we have to make choices, and we made choices to implement e-health interventions on different topics in areas which students themselves indicated that these are topics that they wish that they could have some help with. So, for example, mood-related complaints are quite common, and also students want help with that. They indicated other areas are stress, procrastination, for example, and of course recently also dealing with the corona. So these e-health interventions that we have created are online guided self-help interventions. So that means that there's a structured program. It's based on cognitive behavioral therapy, which is found to be effective both face-to-face and online. However, in students, if you offer these kinds of interventions purely self-guided, so without any guidance, it's not that effective. Whereas if you do add guidance, and you can do this in several ways, the programs are effective. So we've decided to train and supervise clinical psychology master students, which guide the programs by providing a weekly, or maybe more often, it depends on how fast the student is working, feedback on the assignments that the students do, and also they can answer specific questions that students might have, for example. And this is text-based, so it's in the form of email messages. This might feel a little less personal than, for example, face-to-face conversations or a telephone call or video conferencing. But we do hear from both users and the coaches that the contact does feel quite personal, because it's personal issues that you're discussing. And although the interventions in the modules are they're identical for everyone, like how students work on them and what they do, it's different for everyone. So what is unique about this project is that we can create and implement these interventions on our own technical platform. So in the last couple of decades, online help has been implemented on many different areas and on many different platforms, but many of them are not as flexible. So what we can do is we can use our own expertise with regards to the content, and then together with our technical partner, set this up in a way that's ideal for the students that we're working with. Also, we do this in co-creation with students. So they are consulted in every step. So, for example, what is the content of the interventions that you think that we should offer interventions for? what should it look like, how long should the modules be, and of course we ask them at the end of the intervention, what did you think of it, how can we improve it. So everything is done in collaboration with our end users, which are students. This is a brief example of what an intervention would look like. But first, I want to share with you some results of the survey that we've sent out. So, like I said, in June last year, we sent out a survey, and 2 weeks ago, so in January 2021, we've sent out yet another survey. And so here in the Netherlands, like Alexander just mentioned, the coronavirus hit the Netherlands, I think, in February, and then in March we had the first lockdown. And so the survey was beginning of June. It was after the first lockdown, but in the middle of after the start of the coronavirus period. So all the classes were digital, and it was just before the summer break. And in the Netherlands, we are now hopefully at the end of a second wave, in the middle of a second lockdown. So I think this can be seen as a sort of a natural experiment, if it were, because there's different phases with regards to the coronavirus in which the students find themselves. So, I think popular opinion is that in the first wave and after the first wave, there was a consensus that we should all collaborate as much as we can, and in order to beat this pandemic. But then in the second wave, it got a little bit dreary, and it wasn't as optimistic. So we were really interested to see how that might affect the mental well-being of students, for example. So the results that I'm about to share with you are about the impact of the corona pandemic, about some concerns about the pandemic. And also here, my apologies for the abbreviations. These are very technical. This is a jargon. The PHQ is a device that measures depressive symptoms. The GAD is a device that measures symptoms of anxiety. And then the last one is measuring stress. So I want to show those results. So first, in June 2020, we approached about 90,000 students, roughly, at the 4 different universities, and about 10% completed the whole questionnaire. So there are more students that start the questionnaire, but not all finish them. But this is the 10%. Right now, the 2021 measurement, so that was the survey that was sent out 2 weeks ago. The measurement is still in progress. We have 8,000 respondents out of 115,000. So we emailed a little bit more students the past year, which is a response rate of 7%, but the collection is still ongoing. So there's still a couple of reminders to be sent. And as far as I can estimate, I think the response rate will be roughly similar, maybe a little bit more than the 10, 11, or the 10% that we had last year. So here are some baseline characteristics. So the average age is about 22. Most participants in the survey are female. Most participants are Dutch, with about 1/3 of participants being international students. 2/3 of them are bachelor students, the rest are master students. And as you can see here, in June 2020, 1.6% of the students indicated that they've had a diagnosis of COVID, have had a diagnosis of COVID, Whereas in January 2021, this is roughly 7.8%. So that's quite an increase. So right here, there's a list of some consequences of the pandemic for the study progress of students. And these, bear in mind, these are all self-report items that I'm sharing with you now. So this is the percentage of students who agree or strongly agree with the statements that are listed here. So, for example, many students indicate it's unclear how the situation will impact their studies, is roughly a little over half of the students. This is what they answered in 2020. What we see right now is that the number is roughly the same, but there's a slight increase. So I think, oh yeah, so it depends on how you measure the difference. But I've listed the difference here, and I've marked the differences which would be negative for students. For example, a more unclear situation would be negative for students, so I have marked it red, and the rest of the numbers, the differences I marked in green. So as you can see here, yeah, also students indicate that having to follow all my courses online has a strong negative effect on my academic performance. This is a second one that's quite a large number. Then if we go on, then there's another area, for example, mental health, on which the pandemic had an impact. And there's quite a few areas that we asked students what the COVID period pandemic had impact on, and as you can see here, the larger numbers are, for example, causing me to feel lonely, or having concentration difficulties, or having a low mood. So, and if you compare the numbers here. And mind you, these are different groups. I didn't mention that before, but I should have mentioned that. This is important. So these are not the same students that we asked twice. It's a different group of students. However, the students are represented across universities quite evenly, and also with regards to demographics, they're quite evenly. So I think you can compare these two groups, but that is an important thing to bear in mind. So this is two different groups. However, with that in the back of our minds, we do see that on this mental health area, there's quite a few negative differences, and the larger ones, or the largest percentage of students indicating problems is with problems feeling lonely and having problems concentrating, for example. So I'm not sure if you would ask students at different countries these same questions, if the same answers would hold. These are Dutch students, and I know that you are from different from England, from Austria, from Spain. So I'm not sure how it would be in your country, but as many countries in Europe are affected, I'm assuming that at least a part of this would also hold for students in other European countries. Okay, so some more numbers based on behavior. So as you can see here, some positive things to note is, even with the coronavirus, I'm actively keeping in touch with my friends. About 80%, so in June 2020, so it's the majority. This decreased a little, but still 70% is quite a large number. And also about half of the students indicate that they're staying quite active still. Yeah, and also a little more students right now indicate to follow the rules and the guidelines to avoid contamination. So here I list some concerns that students indicate they have about the pandemic, and they could choose from this list what they would find is the most worrisome. And then you can see that the largest worries is that some of my loved ones will be infected. And this is something I recognize myself, and I think Xander also mentioned it in his presentation, and probably a lot of you feel the same way. You're maybe not as afraid to get the coronavirus yourself. I mean, preferably not, of course, but infecting someone else, and even someone who is more fragile, for example, is something you would absolutely not want, of course. The largest increase of a worry is that it will become socially isolated. So we are not sure why that is, of course, but I can imagine that because we're now in the second lockdown. It's winter time here, so a little bit dark days. It's been going on and on. Maybe you have to stay on your room. Because your roommates, they have complaints, and they have been tested, and they have to be quarantined, etc. So I can imagine why this number has increased. That I think is worrisome, and I really hope that soon, we can do something about it. But of course, we have the restraints of the coronavirus roaming around. But I think this was quite worrisome actually when I saw this. There are also some positive consequences that we listed because this is a survey about the mental well-being and things that students are struggling with. That's the main focus. So this is why we don't list too many of the positive consequences, but we asked some. And for example, there are also quite a few students indicating having still a good time staying at home. In June, it was about half. Right now, it's about 1/3, so that has decreased substantially, but still some students are A-okay in this period. Luckily, the majority does believe that the Netherlands will overcome the crisis, so there is hope, and we have to hang in there. Right, so checking how am I doing with regards to time. So 8 minutes, I believe. I think it should be fine. There's a lot of results. I'm sorry about that. Bear with me. I will go through this quickly. So these are the symptoms of depression, anxiety, and stress, which I mentioned before. And in June of 2020, we saw actually that there was an increase with regards to a survey that we administered before Corona of about 10%. And right now, in 2021, we still see an increase. And as you can see here, it's also, well, for example, for depressive complaints, about 10%. And all these differences are very much significant. So it's not due to chance. Right, so the conclusions of our survey are that mental health problems are quite prevalent in students. The prevalences seem to increase over the years, and the corona pandemic does have probably a strong influence on that. We cannot say anything definitely about causal relationships because it's not longitudinal research and it's different groups, but given the circumstances, it does seem that there is a negative impact of the corona crisis. Right, so of course, also bearing in mind these questionnaires were self-report and the response rate was quite low. So there's about 90% of students that did not answer the questionnaire. So that could mean that there's a problem with generalizability to all of the students. This is why for this survey, we will actively chase students who do not fill in the survey in the first instance to see if we can get them to fill the survey out in the second instance by, for example, providing monetary incentives. And this is when a random sample does then, on the second try, fill out the survey, we can, with a calculation, we can calculate the response for the whole sample. So this is something we're working on to address that limitation. I think close monitoring and interventions are needed. So, of course, from caring universities, we offer e-health interventions, but I think as students can use as much help as they can from all different fields and areas. This is just one thing that we can do, but I think students are in need of help at this time. Right, so I briefly want to mention some results of the e-health interventions that we're offering. So right now we have 4 different interventions: one to increase mood, one to decrease stress, one to combat procrastination, and one geared towards dealing with corona-related issues such as loneliness, concentration difficulties, etc. The numbers I will show here are from November. And as you can see here, the average age is about the same as the students that filled out the survey, 22. Majority is female and the majority is Dutch. So in November, we had about 400 students with active accounts. So right now, we have 2 more interventions, and because recruitment also started in January, we have a lot. So now we have about double the number. So we have, I think around 900 students with an active account right now. And the procrastination intervention that was launched also 2 weeks ago is proving to be quite popular as of this moment. So in here you can see the use of, for example, the program targeting mood-related complaints. So it's a common theme in eHealth that not all the users complete the intervention all the way through. And although we do not know that that's absolutely necessary, that is, of course, one thing where the programs are built on, are geared towards. And we know that within the student population, this is actually even more of an issue than with the general population, for example. So we see that there's quite a few students that start the intervention, and then after a couple of modules, they drop out. But also there are quite a few that go towards the end or even finish the interventions. It's important to note here that we do want to provide these interventions like on a very low base threshold. So we want easy access and as geared towards what the student wants. So if there's a student that says, hey, I'm okay with doing like 2 weekly lessons, I've learned a thing or two, my mood has increased, I'm done, that's fine. So we're not here to force these interventions on students, but of course we do hope that they're as effective as they can be. A similar pattern we see for Relax, which is the intervention targeting stress. And we also asked the students what their reasoning were with regards to dropout, and we see that the majority of the reasons that students indicate are personal. Some don't have time, some are not interested anymore, and some indicate that the symptoms have improved. If we look at the actual results, for example, here is the program targeting mood. So we see that the mean at the start is 9.5 points, which gets reduced at the end of the program to about 6 points. And we see a similar thing for stress measurement, a decrease of about 4 points. And this roughly corresponds to a moderate to large effect size. So that's in the literature of clinical psychology, a good effect. And for example, you as a student, you would have like 3 or 4 symptoms. So your concentration would be better, for example. You would have less stress. Your mood would have been increased. So you would be progressing on 4 different symptoms, so to speak. We see a similar pattern for relax, and I think I'm looking at the time. I think I'm running out of time. We also asked the students how satisfied they were with the programs, and they indicated that they are satisfied. So the 70 or 87% would recommend the program to a friend, and 49% indicated to be satisfied or very satisfied with the service. So conclusions of the e-health interventions is that dropout is high. However, symptoms do improve in general, and the users are satisfied. So I think this is a positive message. However, we do want to seek out measures in order to engage the students more and reduce dropout. These are some members of the steering committee of CAM universities and members of the science committee. And with that, I want to thank you all for your attention and want to open the floor for questions if we have time, actually.
Thanks very much, Sasha. And we've got time at the end for questions and discussion with all the speakers. But there is a moment now if anyone's got anything, particularly a sort of factual question or clarification.
There are a couple in the chat as well. I don't know if you saw those come in, Neil.
Yeah, do you want to pick them out, Kelly?
Yeah, Sasha, can you see on the chat you've got Emaine and Mirko have just made a couple of comments. The last couple of comments in the chat. Can you see them?
Yeah, I see Emaine and Mirko. And Emaine is asking, I think Spanish students might have the same problem. So as students, what should we do to help people who are coping with loneliness due to COVID?
That's right.
Yeah. So I think that's a very good question, and I think it's a question that maybe more students are struggling with or dealing with. I think, yeah, first and foremost, there's the boundaries that we all should be aware, and that you cannot see as many people, and of course at the appropriate distance. So in the Netherlands, for example, is 1.5 meters. So I think within those boundaries, try and stay in touch with as many people as you can. So, for example, go out for a walk, maybe especially with someone who you think might be struggling, or you did not hear from him or her all that much. Try and reach out. Use the phone. Use video conferencing. There's quite a few digital means available in order to stay connected. Some things that I've heard students mention, what they do is that they have their a group of friends, for example, or maybe study group or some other group activity, and then every morning they check in with one another. So, for example, you can, maybe use Zoom and then be together at that video conferencing tool. And start the day and just check in, like, hey, how's everyone feeling? What's everyone going to do today in terms of schoolwork, for example, or yeah. So I think try and stay in touch as much as you can within the current boundaries that we all have to face.
Thanks very much, Sasha. And I think we can return to this issue later on. We've been going for an hour and a half, and I'm going to suggest we just pause for a break for a few minutes. We have our third and final presentation, which will start at in 15 minutes, which is 3:45 UK time, and it's something else 45 if you're not in the same time zone. So I think if we say thanks very much to Xander and to Sasha for those two presentations. More discussion to come, but let's pause for a break, get a coffee or something, make yourselves comfortable, and then we'll reconvene in 14 minutes with our third and final presentation from from Paul Hunter from here at UEA. So thank you very much, everybody.
Okay. Thank you, Neil.
That's if you're back. Are you back there, Kelly? Hi, Kelly. You back with us?
I am.
I was just wondering about bringing Paul up to being a presenter, but I see he's appeared in the presenters. Great.
It's because he logged out and logged back in again, and I missed his message where he told me he'd done that. So we're all back now.
Yeah.
Okay.
Yeah, I just had to move to a different room for the if you're going to see visuals.
Okay. Well, welcome, Paul, and welcome back, everybody. I think we'll move straight over to Paul's presentation, which is going to be about COVID and the UK. So over to you, Paul.
Right. Is that full screen for you at the moment?
Yes, it is.
Yep.
Brilliant. Okay. I'm Paul Hunter. I'm professor in medicine at the University of East Anglia, and I'm a medical doctor specializing in medical microbiology, infectious disease, and especially epidemiology. So what I was asked to do was talk you through issues around COVID in the UK. And essentially, I think just to sort of explain what's been happening in the UK, as far as I understand it, at least, and some of the issues that's arisen during that time. And so, next slide. There we go. Oops. Well, I first became aware of this problem back in, I think it was the 2nd or 3rd of January, where this was a post. There's a email service called ProMed Mail, which circulates to anybody really, any notifications of potential infectious diseases of interest. And for years, I've tried to keep a check on this to see what's coming down elsewhere in the world. And I saw this back in January. Now, January in the UK, we actually had very few cases. We had, in fact, 3 cases and no deaths, as you can see here in January. The first case, or the first 2 cases, were in Chinese nationals, one of whom was a student at York University, and they'd been staying in a hotel when they got sick, and that was that made the news in a big way for the first half of the week of February, whilst bits of information about this eventually leaked out to the press. And then it went quiet a bit, a few more cases, until towards the end of February, when we started seeing a surge of infections. Now, the first within UK spread that we know about was actually related to an issue in France and a ski chalet in France. And one patient one of the cases, the index case, had come back, I believe, from a meeting in Singapore, infected several other people in the ski chalet before returning to the UK, whereupon he was responsible for infecting a number of people in the in his local surgery, where he went because he was feeling ill. After the end of February, as we moved into March, really that's when it took off in a big way. And here you can see a very steep increase in cases throughout March of last year, and the appearance of starting to see deaths. And at the time, at the end of March, over 600 deaths in a day seemed like a huge number of deaths, and it was, but it still continued to rise, sadly. I think the other thing about March is that I first made the headlines in my own right because Holly Willoughby, who's a television celebrity, on air refused to shake my hands after speaking to me, and that made headlines across many newspapers around the UK. I hasten to add that actually I told her not to shake my hand because of the risk of spread of COVID, but that's not quite how it was reported. The other big thing about March was when we started the lockdown, and on the 23rd of March, the country went into a national lockdown. It wasn't the first restriction in the UK, because I was in London a week before that, and it was very obvious that London was pretty much dead a week before the national lockdown. So we were seeing substantial reductions in social interactions in the capital a week before the official lockdown happened. And some of the lockdown deniers have pointed to the fact that deaths started to decrease sooner than you'd expect with the March 23rd lockdown. And the reason was that most cases were occurring in London, and London effectively went into lockdown a week earlier. So how did COVID get into the UK? Was it a single introduction? Was it all traced back to that Chinese couple in York, or the English guy who'd come in from France? One of the big advantages to investigating epidemics these days is the ability to sequence strains and to actually then make reasonable assumptions about how infections spread. And this is a graph produced by one of the main groups that are collating gene sequences in the UK. And I think the UK has sequenced a higher proportion of its positives than I think any other country in the world. And one of the things here is that actually looking at the sequences, it was obvious that we didn't have just one or two. We had hundreds of separate introductions of COVID into the UK. Initially, they were all coming from Italy. Then Spain became the next primary source of a large number of introductions into the UK. And finally, France was then the next big source of introductions. And this is important because back in March, there was a lot of talk about banning flights from China and how can we stop Chinese people coming into the UK and potentially bringing COVID. I mean, this graph basically shows that if we'd done that, it would have been pretty useless because it wouldn't have actually done much to control the spread of COVID into the UK. And in fact, this is one of the things that we do know historically from many epidemics and pandemics in the past, is that travel restrictions rarely actually make a lot of difference unless you happen to be fortunate enough to live on a little island thousands of miles away from your neighbours. But you can't really rely on travel restrictions in most industrialized Western countries, and we are seeing a reintroduction of travel restrictions at the moment. Again, probably far too late to actually do anything. Then case numbers started to plateau in April. But deaths, fortunately, having peaked at around the 10th of April, started to go into a steep decline. So why was that? And were the number of deaths as bad as those figures looked? So let's just have a look at something about deaths. These are the total deaths recorded each week. And you can see round about March, April, there was a huge excess of deaths occurring, and then not much until we got into the autumn, when excess deaths started appearing again. And all these other lines represent other years, but the one in orange is the last year. We're already, the first week, we're up at about 17,000 deaths in the first week of 2021. And also we're starting off this year well above the average. Now, that that's interesting, but it doesn't tell us everything. It doesn't tell us what those deaths were. So what I've done here is look at the number of reported COVID deaths, which are the orange line, and the blue line, which is the number of excess deaths. And the excess deaths, basically the number of deaths over and above the average for the previous 5 years. And I think there's a couple of things here of note. And the first is that excess deaths substantially exceeded COVID deaths during April. And then they pretty much disappeared. And since then, excess deaths have never really exceeded COVID deaths, except towards the end of August when we had a heat wave. And that sort of peak that you can see around about August is almost certainly deaths associated with the heat wave that we had during that month. The interesting thing here really is that why is it that we had so many excess deaths in April? And a lot of the COVID skeptics were saying this is because people have been dying for other things because they couldn't get into hospital. What this graph to me shows is that actually what was happening is that in April we were pretty rubbish at diagnosing COVID, and a lot of those deaths, those excess deaths that weren't diagnosed with COVID, were almost certainly were associated with care homes for the elderly, nursing homes, where actually we were not diagnosing COVID in April. We did not have the facilities in place in the UK to diagnose people dying in care homes in April. That is a real stain on our response to this epidemic, in my view. This graph here shows deaths just in care homes to prove my point. You can see here that the number of deaths involving COVID increased substantially in April, but also non-COVID deaths increased substantially in April, before slightly falling below the expected deaths. And one of the other issues that skeptics have said is that actually all these people who died, they would have died pretty soon anyway, so it's not really that important. The reality is that actually, and that is, there is a technical term for that, and it's called harvesting, where an infection kills a lot of people, but that people who would probably have been dying in the next few months anyway. And although there was almost certainly some harvesting going on here, it was nowhere near as obvious as the excess number of deaths. So even in care homes, COVID wasn't killing people who would be dead within a few weeks anyway. It was killing people who still had many months and possibly many years of life left to them. And this is some work that we did, looking at how COVID spread into nursing homes. So why was nursing homes such an Achilles heel in the UK, and indeed in other countries as well? And Spain, big problems with COVID in its nursing homes. I think there are a number of issues here. The first is that actually what happened was, in order to clear wards for hospitals to take care of incoming patients with COVID, a lot of patients who were actually infected with COVID were allowed to go into nursing homes where there was not enough resources for them to be cared for safely, because the UK didn't have enough PPE, personal protective equipment, for its hospitals or its care homes, and it focused what it had in its hospitals. And to a large extent, the reason for that is that we've been gradually running down our stocks of emergency supplies for a number of years to save money. And we'd got a range of what's called just-in-time purchasing agreements, so that if there was a major disaster, companies that we'd got contracts with all over Europe would be able to deliver us PPE at a drop of a hat. And nobody who wrote up that contract ever thought that actually if we had a global pandemic emergency in the UK, pretty much every other country in Europe would also be searching for limited supplies of PPE. The other big thing, and this is a particular issue in the UK, is that people who work in care homes have very little job security. They are very lowly paid, and many of the people to make ends meet have to work across multiple homes. And so what was happening, particularly in London, was that people who were working in care homes would do a day shift in one home where they had COVID, would go and then do an evening shift in another care home and take the infection with them. And even if there was restrictions being imposed on the initial care home, and that again was a tragedy that was allowed to happen. The other thing we showed in this paper was that actually once the infection was in a home, how readily it spread was largely determined about whether they or not they had enough PPE. Right, going on till May. Well, as I already said, that April case numbers didn't appear to be going down that much, and the reason for that actually was because at the beginning of May we were pretty dreadful at having enough tests to go around, which built up towards the end of May. So built up towards the end of April. So during April, we were missing huge numbers of cases because we just didn't have the tests available to screen people. And so that although case numbers were almost certainly declining, testing was going up. So that's why it appeared flat. But in May, things got a lot better. And obviously, as you can see from fatalities, the death rate as well was decreasing quite substantially in May. So what led to this decline in cases? Well, there have been a lot of arguments about whether the value of the lockdown in controlling cases, mainly by people who really didn't see why they should, gave precedence to other issues than human life. But we heard from the first speaker a very good economics lecture about why actually, even if we'd done nothing, it wouldn't have, we would still have had a fairly hefty economic hit on society. This again is some work that we did, and we looked at the course of the epidemic across multiple European countries, some 30-something countries. And the big things were closing schools, banning mass gatherings, and what is euphemistically called initial business closures, which was sort of usually those bars, clubs, restaurants, entertainment venues, those sorts of things that were tended to be closed first. So that most of the impact across Europe was closure of these places. Forcing people to stay at home, if they could, didn't actually have that much of a value, and it may have had some negative value, but although the big problem with these graphs is that they look as though their y-axes are actually all different, so the impacts sometimes look bigger than they are, but certainly school closures, mass gatherings, and entertainment, that hospitality venues did appear to be the main value in terms of closing. And this is interesting because a lot of people were arguing for many weeks actually that closing schools wasn't going to control the epidemic at all, and and managed to get their papers into some of the top journals, despite the fact that I probably wouldn't have got them through. I wouldn't have approved them if they'd come to me to peer review. The other thing about May was that we did start seeing a degree of relaxation, and we had some very warm months in May where some of our beaches were packed. People went to the beach in droves, and there was concern that this was going to lead to a substantial increased risk. And actually, it was very difficult to demonstrate any impact, and I tried, of this going to the beach. And that's probably because actually being out of doors isn't that much of a risk. There was a very good quality Japanese study that showed that if you have a contact outdoors, you're about 19 times less likely to spread the infection than if that is indoors. So being outdoors is a much lower risk activity. Oops. Now then, as we went into August, to the end of August, I've jumped a few months now, cases continued to decline pretty much throughout June and then started to drift up again in August, but not deaths. We didn't see really any increase to speak of in deaths towards the end of August. And again, there was a lot in certain aspects, a lot of comments in some aspects of the UK press that actually this means that we didn't need any more restrictions because COVID wasn't killing anybody anymore. One of the big things, though, about June was that one town in particular, Leicester, really still continued to have a problem, and case numbers were still very high in Leicester. And there was all sorts of issues going on about national government not sharing information with local government, or at least not in a way that local government could actually do anything about this cluster. And I think one of the key findings of this ultimately was that probably this mini epidemic in Leicester was being driven by the rag trade, clothes manufacturers, that were paying very low rate, piece rate work, low paid work, people living in poor housing, multi-generational occupation, and that very little in the way of adequate health and safety was being done in these sweatshops. And almost certainly that was a major cause of the Leicester outbreak. The other thing, somebody had this really good idea in August that to help stimulate the leisure industry and restaurants, they would subsidize meals on 3 days a week, Monday to Wednesday. If you went out for dinner, the government, the taxpayer, would pay half your bill. And what happened then was that actually everybody crowded into restaurants on Monday to Wednesday. So you find many restaurants that were really packed on Eat Out to Help Out days, and other days not so much. But it did increase the income for the restaurant trade, but at a cost in terms of the epidemic. And I think there is very little doubt that actually that was one of the reasons why by the time we'd come to the end of August, we were still seeing quite a large number of cases. For me, my wife and I thought it was good, because if we went out on a non-day, we could go to a restaurant and we were almost the only people there. And so we could feel quite safe, but everybody else was packed in on days that were too busy by far. The other thing about why were there so few deaths, and I think this graph, of which I'm actually quite proud of, I think it's really pretty, and this is age bands, with the blue at the bottom representing case numbers per each day in the 0 to 20s, 20s to 40s, 40s to 60s, 60s to 80s, and the over 80s. And the big thing, as you can see on the left, is that early on in the outbreak, it was nearly all older people certainly over 40 and pretty much over 60 that were getting the infection. And this tied in with the fact that it was a lot of this early epidemic was spreading in older age groups in care homes, and also that we weren't actually screening a lot of people in younger age groups. And by the recent times, we see a much smaller proportion of cases occurring in the older age groups than we did, especially in the over 80 age group, than we did at the beginning. And I think in part, one of the reasons why the case fatality rate has fallen quite substantially, and you can see this here. This shows the proportion of tests positive and the total number of tests positive and tests done. You can see that generally at the start of the outbreak, much higher proportion of tests were positive. That fell, and then as the epidemic regrew again in autumn, it started to go up. So deaths were probably low because many of the cases that were being diagnosed now, a lot more of the cases that were being diagnosed were young people who weren't going to die, fortunately. And again, that is why certain sections of the press were wrong in suggesting we should use that as an excuse for reducing the restrictions. Now this, again, now we've moved up to the end of November. The first thing to note is that actually, at about 2 weeks after schools went back, case numbers started to rocket again. And case numbers hadn't actually been as low as we would have wanted them to be at the end of August for a number of reasons, which I've already discussed. The other thing is to note the peak back in the spring is beginning to look quite small now, although the death rate in the spring was still quite high. And ultimately, we moved into something called a tier system, where each local authority in the country was deemed to be tier 1, 2, and 3. And in tier 3, restrictions was the most. You couldn't visit people in their own home, and you couldn't, and you could only go to a pub if it was operating as a restaurant. In tiers 2, you could go to bars and pubs, but not in tier 3. And this was introduced about here and about 2, and it's difficult to see on here, but within about a week to 10 days, it did seem as though we were getting some level of plateauing in cases as a result of this tier system. But this is a box and whisper plot, and this is looking at the R value in the different tiers, and it's a bit, maybe a bit difficult to see this, but you can see that in tier 1, the R value remained stubbornly above 1, so that in tier 1 authorities, the epidemic continued to grow quite rapidly. In tier 2, actually, until we got to the last week or so, the epidemic mean was about 1, so that by and large it was beginning to level out. And in tier 3, the most strict one, was actually quite effective at bringing down the R value. There are a couple of things, though, to note, and that as you see from the last week, the R values across local authorities started to rise in pretty much every local authority. And so we moved into another national lockdown. And we can see here, this is other work that we did, that the lockdown was imposed about in the middle of the graph. And then after the lockdown was imposed, there was a surge in cases before starting to decline, but again, this sort of slight rise towards the end, which was quite worrying. Now, if we look at this a bit more carefully, the graph on the left shows the incidence by region, and most regions saw a peak in early November, apart from the Northwest region, before cases declined. And then as we got to the end of the lockdown, case numbers started to increase again in London and the southeast. And we can see here that actually, if you broke that down by tier system, local authorities in tier 3, which started off with the highest instance, case numbers dropped substantially, but there was this peak in tier 1 and tier 2. Now that peak occurred predominantly in adults in early November, and almost certainly and that was particularly obvious in the 20-year-olds, and almost certainly what was happening there is that was linked to the fact that we're going into a lockdown was leaked 5 or 6 days before it was implemented, and people went out to the pubs a lot more in tier 1 and 2 authorities, but not 3 because the pubs were closed, and that led to a surge in infections, which actually ultimately probably removed the benefit of going into national lockdown. But then case numbers in many areas, age groups in London started to increase, and that was very concerning. And it was most notable in children of secondary school age, where the disease was spreading. And we now know that wasn't because the lockdown failed, it was because of this new variant. And we can see here, the top, that over a 2-week period, the new variant increased substantially during lockdown, whereas all the other old variants together declined markedly during lockdown. So we had a problem. Taking it through to recently, we are in another really big surge in cases. Our National Health Service is under more pressure now than it was in spring. We are in a very bad place at the moment with the epidemic in the UK. And that is almost entirely down to this new variant, which is substantially more infectious. It's given the name variant of concern 2020-12/1, and you can see here the dark blue is this the new variant, or at least it's called the SGTP, which is because this new variant, one of the targets for the PCR doesn't work against the new variant. So it's the spike gene target failure is something that we can use to find determine which of these new variants. Which is this new variant, and we can see from here that, and particularly the top row of maps, that how this new variant effectively started in the southeast, as was suggested by the graphs that I've showed you, but has effectively now spread throughout the UK. It is substantially more infectious, by about 50 to 60% more infectious than the previous variants, but there is no evidence that it increases the risk of severe disease or hospitalization, and no evidence that it increases the risk of death. And in fact, it doesn't. It does seem to be still as no more or no less severe than the previous variants, but a lot more infectious. And of course, we couldn't not share this with everybody else, and this is the UK's gift to the world. And all of these countries that are shaded in orange have either got the English variant or at least are thought to have and are waiting confirmation. So it has spread globally. This, I don't know if you can see this very well, but these are the status with a number of the key variants. The English variant, which is its lineage is B.1.1.7, and you can see here that at the end of December, this had been detected about 5,300 times in the UK, of which 3,500 had been in the previous 28 days. So it was increasing fairly rapidly. There's the South African variant, which was only present, we'd only got found 9 times. The English variant does seem to be, it's not an escape mutant in that it still seems to be affected by antibodies and in people, whether they've been naturally infected or vaccinated. The South African variant has got a E484K mutation, and that actually is an escape mutant, and it has the potential for not being controlled by vaccine. There is another Brazil variant, which is called P1. Well, there are 2 Brazil variants, P1 and P2. P1 is the variant that people are worrying about, and at the moment, that's not been detected in Europe as far as I'm aware. Now, since then, as of today, what was 5,500 examples of the new variant back at the start of this month has now become almost 17,000. So it is spreading rapidly in England. The South African variant was, we only had 8 or 9 cases to the end of December, but we've now got 54. So that is a concern because that might have problems with the vaccine, but probably won't. And the Brazilian variant, which we've not seen at the moment. Speak. So why are these new variants arising? Well, it's very simple. If you look at the places where they've arisen, the countries where there have been most cases, there is nothing special about England, Brazil, South Africa, other than the fact that they've done worse than most countries at being able to control the epidemic and have seen very large numbers of cases. And that's the thing that drives the appearance of new variants. There are actually, having said that, hundreds of new variants around. There have been thousands, tens of thousands of mutations in COVID, in SARS-CoV-2 over the last year, but most of them don't actually do anything different. Occasionally you get these variants that are more infectious. The first one was back in January, February, very early on in the epidemic, D436. Anyway, it begins with a D and ends with a G, and it's got a 4 and a 6 in it somewhere. This variant was more infectious, and it appeared back in late January and then rapidly became the dominant variant globally. And the same thing is likely to happen with these variants and possibly any new variants coming along. So the way we could have prevented this was actually being better at controlling the epidemic earlier on. So what of the future? Well, I think basically we will get through this surge of infections, and there are already signs that case numbers are already declining in the UK in the last few days. Hospitalizations, early signs that they may now be falling, and deaths might be plateauing. But there are a number of big uncertainties. People still talk about herd immunity. Herd immunity is not going to happen with this virus. There are other human coronaviruses that are very similar to COVID that we've had circulating for decades, indeed centuries, in human populations. And we do not and will not ever get herd immunity to these viruses because immunity is relatively short-lived. And herd immunity can only really happen if your immunity lasts for a very long time. So herd immunity isn't going to be an issue. And what that means is that even once you've got up to the 60 or 70% of people, because people will lose their immunity and because people continue to get repeat infections, albeit not as much as people who didn't have previous infection, they will still continue to spread the infection. But Mirko, we are not doomed, because the time you get your second infection, it generally is much less severe than the first section. So what happens with these other variants is that our toddlers, children, get these infections multiple times before they go to school, and by the time they're adults, by the time they're at an age where they could suffer severe harm, they've already got pretty good immunity. So although they can get infected and they can still pass on the infection, they don't get the severe disease, and we don't see the severe disease very often with these other human coronaviruses. Again, another big problem is these, we may well be seeing some of these escape mutants in the future, which will reduce vaccine efficacy, but not to a degree that makes the vaccines unhelpful. And the reason for that is that all these escape mutations happen at certain points in the spike protein, and there are still lots of other places for antibodies to interfere with the virus. So you see this even with other human coronaviruses, that although you gradually drift, you don't get the big shocks that you do with pandemic influenza. So yes, we will see more new variants, but the vaccination program will reduce again and the likelihood of severe disease. So what happens next winter? I think we will continue to see COVID over the next winter. I think we will have another spike in cases, depending on how many people who have in vulnerable groups have declined vaccination. If there are a lot of people in those groups that have declined vaccination, then we will likely to still see more severe disease and deaths. But if we manage to get vaccination across to most of those, then hopefully it won't be anywhere near as bad as we've seen this year. But the other thing about vaccination is that we know vaccine stops severe disease and deaths, and it stops symptomatic disease, but we don't know whether it totally stops spread of infection. There is some evidence that vaccines probably won't stop people spreading the infection. We're still waiting to be certain about that. And with that, I think that is my time up.
Thank you very much, Paul. That was a very rich and detailed account of the UK situation, and I can see that there are some comments and questions in the chat, which I think we should turn to. I've got a question of my own, but I think we should look at the students' questions first. So Mirko does ask if you know anything about a German variant.
No, I don't actually. It's not. I don't know whether is it a variant that appeared in Germany, or is it one of the existing, because there are 3 variants of concern in the world at the moment. There's the English one, the South African one, and one of the 2 Brazil ones that are of concern because they are potentially escape mutants, but and they're more infectious. But I don't know what the situation is in Germany. Sorry.
And Xander raised a question about herd immunity, but says that you've addressed that in your final comments. And you picked up Mirko asking, so are we doomed? So I think we've probably,
yeah, we are, but possibly more. Yeah, we're doomed from climate change, actually.
Can I encourage our student participants to have a think about anything else you'd like to ask? We've got, I mean, a couple of things to say here. We've got very, very fresh research. You know, this is very rich current studies of an evolving situation that we're really in the middle of, and we've got leading authoritative academic researchers in their fields and in our respective countries here talking to us. So it's an opportunity for you to ask any questions you've got of these leading academic researchers, and a great opportunity for you to find out more stuff. So please do feel free to type in questions in the chat. I would just like to ask Paul, and perhaps Xander might want to come in as well, but obviously we've structured the session around what's going on in the individual countries, but I wondered whether you just have any thoughts on what you think are the most important and significant differences between the approaches of different European countries. The participants that we've got on the session come from England, Netherlands, Austria, Scotland, Iceland, Germany, Spain. Is there anything that you would point to as a significant difference in the national approach to COVID that has had an impact on the way that the outbreak has evolved?
Well, I think people talk about Sweden a lot, and you know, for people of a certain political leaning in the United States have been lauding Sweden quite a lot over this year, probably not realizing that Sweden has a left of centre government. But and I think Sweden took a much more relaxed approach to this, and you can see that in the deaths. Although Sweden isn't as anywhere near as doesn't have the same death rate as we do in this country, it is still pretty much one of the highest death rates in the world, and substantially higher than other Nordic countries, Finland, Denmark, and Norway. And so, yeah, I think Sweden did. I think it's clear that the Swedish approach led to quite a large number of unnecessary deaths. Without and listening to the first presentation without maybe protecting its economy, but it'd be interesting to see what the Economist thinks about that. Sandra.
Yeah. Yes. Thank you. I've closely followed the policy decision-making process in the Scandinavian countries, and it struck me that the National Public Health Institutes of England, the Netherlands, Denmark, Norway, Finland, and Sweden pretty much all advised the same policy. And it was actually the politicians in Denmark, Norway, and Finland who decided otherwise. This has led to quite a bit of discussion in especially Denmark, as the National Public Health Institute felt overruled. So what I want to say is that the Dutch policy and the Scandinavian policies and the English policy back in February weren't actually all that different. They had very similar views on how to deal with the disease and to how to approach this. And it was policy. I think it was the political process was slightly different. And sometimes, like in Denmark, it was just an individual, like the PM in Denmark was a woman who just individually decided otherwise. and to close the borders and to have a mild lockdown, as we would now refer to it, in early March. Now, I think at the time it was probably difficult to with any certainty, any degree of certainty, to decide which of the policies was best. But by now we can tell that the economic consequences of the policies in Sweden were about the same as they are like in Finland and Denmark. The Norwegian economy is slightly different, so it's not easily comparable. But what we also see, I think the forecast for 2021 for the economic development is actually better for countries that have a better level of control. So we do expect that at the end of this crisis, we'll see that Sweden has been outperformed in both in terms of less health damage and better economic growth by the other Scandinavian countries. And the Netherlands, I think, has had a fairly similar policy as Sweden, although we've had a more difficult political process, and there was less of a discussion in the public, and less clarity about our policy goals, making it very difficult to disentangle what the actual policy is that we followed in the Netherlands.
Yes, thanks, Andrew. That's really interesting. Looking in the chat, then we're getting quite a nice flow of questions and comments. Paul, there's a question from Nicola. Why is the new variant more infective than the first one?
Well, we don't know for certain. There are some worthwhile suggestions, however. The first is on a molecular basis. The mutation in the English variant, which you also see in the South African variant, is that it binds much more tightly to the ACE receptors on cells, which are the receptors that the virus gets hold of when it wants to get into the cell, so that there is a biological mechanism that is plausible. The other thing is that it does seem to be the case that people who are infected with the English variant and the South African variant tend to have higher viral shedding compared to the older variants. And if a case is shedding more virus into the environment, it's going to be easier for people in that environment to pick it up. But those are the two explanations. But to be honest, I don't think we have a totally good idea at the moment.
Thank you, Paul. Just a couple of comments and questions that I might group together. So Lucas asked, what do you think about the AstraZeneca vaccine? And Natasha asks about the issue of the second dose of vaccine being delayed.
Right, yes.
A question about how long immunity after one dose might last.
Yeah. Oh gosh, yeah. I mean, I've had more irate emails from people over some of these issues than anything else. The first thing to say is that I think it depends what you're looking at. I think the Oxford AstraZeneca vaccine and the two mRNA vaccines seem to be very good at stopping people getting severe disease and ending up in hospital and dying, and presumably dying, although we don't know for certain that, but that's a pretty safe assumption. For mild disease the Oxford vaccine typically is said to have an efficacy of about 70% compared to about 95% for the mRNA vaccine. So that superficially the mRNA vaccine, well, not superficially, but the mRNA vaccines do seem to be a lot more effective than the adenoviral vector vaccines like the Oxford vaccine at mild disease. But again, probably both are still very effective against more severe disease. We do know that the Oxford AstraZeneca vaccine probably doesn't generate sterilizing immunity in everybody, and in the phase 3 trials, people were still getting PCR positive nose swabs, even though they weren't symptomatic, and it wasn't that effective at reducing that risk. So there is a potential, certainly with the Oxford AstraZeneca vaccine, you could still be infectious to others even after effective vaccine. There is currently no available data for the mRNA vaccines on that, but they are looking at looking for antibodies to other proteins on the virus that would be a hopeful surrogate to look for recent infection with the with all of the vaccines. Looking at non-human primate studies early on, the mRNA vaccines did stop nasal shedding, but the Oxford AstraZeneca vaccine didn't. But having said all that, I still would go for the I would take whatever I'm offered. I think they're both brilliant vaccines, and I'm in my mid-60s now, so I've got a non-zero risk of dying if I do get COVID. So yeah, I'll go for either of them. The increasing the gap, it's quite interesting actually. I was at a WHO meeting the other day, and I was expecting there to be a lot of on vaccines and COVID, and I was expecting there to be a lot of pushback against that. And actually, the impression I'd got is that most of the people talking were actually thought it was a good idea from around the world, and these were speakers from around the world. And I think it's a brilliant idea. I think the evidence is quite strong that if by increasing the gaps and therefore giving more people the first dose is going to save a lot of lives, and I've got very little doubt about that. There is pretty good, there is excellent evidence for the Oxford AstraZeneca vaccine that if you increase the spacing between vaccines, then you actually get a better immune response anyway with the Oxford AstraZeneca vaccine. And although that seemed to have come as a surprise to a lot of commentators, it was not a surprise to me, because this is known for people who've worked on vaccines. Pretty much every vaccine that you give, you get a better response the longer that you can leave it, within reason of course, between the first and second dose. And we know from animal studies, and we know from other studies that immunity and antibody levels do probably lack. You're probably, even after a single injection, you've probably got good immunity for at least 6 months with any of them, I think. And that is not overly surprising, because you see this with pretty much every other vaccine. So I'm a big fan of increasing the gaps, and a lot of people who came out against it early on are actually now changing their mind once they've thought about it and actually looked at the evidence. Over.
Okay, thank you. I can see there's a question for Xander from Mirko about being badly prepared due to cost cutting.
Well, what I can say about that is that like he might be referring to cost cutting in healthcare, but I think there is no evidence for cost cutting in healthcare. We've been just expending healthcare expenditure pretty much every year at a growth rate beyond the national economy. What I will say is that many countries have not. I think all European countries have not met the suggested percentage of GDP spent on public health. So especially like the preparation for pandemics, for example. Now, there was a ranking of countries based on preparedness for a pandemic, and I think it was the UK was leading the charts, followed by the US, and I think we came in third, and we were pretty proud of that third position. And of course, these were the 3 countries that have like performed terribly. So you could say that we were spending slightly more in preparation, yet did worse. But that, I think, has more to do with the actual choice in the beginning of the pandemic, to opt for a allow the virus to spread policy, mitigate it to make sure that healthcare would be able to cope. But that principle really, I think, was the original cause for these countries to perform slightly worse than countries who've tried to, like Germany or Taiwan or Australia and New Zealand and you name it, who actually tried to contain the virus, even though they didn't fully manage. Were able to outperform in terms of health and economic consequences.
Yeah, can I add? Actually, I mean, certainly in the UK, during austerity, although healthcare wasn't really negatively impacted as much as other sectors, what was seriously impacted was public health, and particularly infectious disease public health. And a lot of my colleagues. 20 years ago, we had a big network of public health laboratories around the country that could have handled a lot of the testing early on, and actually there was hardly anybody left who could do that. And so that right at the beginning, we were failing because we didn't have we'd closed down a lot of the infrastructure that we ultimately would needed, and then we subcontracted all this work to corporations who've never really done this sort of work before in the past and wonder why they haven't done it well. So there are and a lot of my colleagues who worked in public health, have had to take early retirement. They've been thinned down, and the increased bureaucratization that comes with being brought into the civil service. The worst thing you can do to public health is make your public health part of your Ministry of Health, that they are civil servants responsible primarily to keep their minister looking good, and that, I think, has been a big source of failure in the UK.
Okay, thank you, Paul. Can I just remind participants that we still have Sasha with us, and so there's an opportunity to ask questions about the student well-being dimension to COVID. And Kelly's just put up the slide about the interdisciplinary community service learning project. Just a reminder, if there's anyone who's a master's student who might be interested in getting involved in that project, there's an email address at the bottom of that slide, so you can find out more. Sasha, is there anything you'd like to come in on the basis of what you've heard in the questions and the discussion so far before I turn to the next question?
Well, I think everyone is anticipating how the vaccines will work and what the new corona strains will and will not do. And I think it affects mental well-being, not only for students, but for societies worldwide. So I'm actually very much in anticipation of that as well. And I think, yeah, in the meantime, we should try to keep as fit as possible, physically and mentally, but it's quite a challenge. If anyone is having any questions with regards to that or anything else with regards to the presentation that I just gave, let me know.
Okay.
I've got a couple of questions for Sasha. I'll pop them in the chat, Neil.
Okay, thanks, Kelly. Yep, we'll look at those. We've got another one from Nicola. And again, I think it's for Xander. We keep talking all the time about trying to save economy.
Yeah, I think the issue here is that many students or many people assume that if people are in good health, that they're more productive, and therefore investing in health is investing in the economy, and that is untrue. I'm sorry to say. I wish it were true. But the thing is that when we invest in health, we're typically investing in people that are no longer productive in the economy. So, and I think that is true here. So what we observe is that there is a group of people active in the economy that doesn't really suffer as much from this disease or any other disease. And it's not very different for cancer or for heart disease. And you'll see that the group that is suffering is the part that's not participating in the economy as much. So, yeah, the natural looking at this as in there are two groups in society, and there is a tension in the interest of both groups, and and it's a choice between one of the two. That's it's natural. It's natural for politicians. It's natural for journalists to look at it from that perspective. I think where it all comes together is that because people care so much, not just about their own health, but also about the health of their significant others and people they care about in general, and perhaps also the health of people that they don't care about, or they don't know personally, but they care about, not like affecting health of others, has changed behavior quite significantly. So when people start to behave differently, it's when they start hurting the economy. And I think that making sure people feel safe also allows them to go back to their daily business in the past, as in Australia. I mean, just look at Australia and you'll see what I mean. And therefore, guaranteeing, like creating safety, is also the way to get the economy running again. And that's where these things come together. But very few people have seen this point. Typically, people in public health have not got the knowledge to understand how the economy works in enough detail to make this point.
That's great. Thank you very much. I can see there's some more questions and comments coming through. Perhaps if we go to Kelly's questions for Sasha, about the timings of your survey and about extrapolating your findings. So that's a comment at 1648.
Yeah, thank you, Neil. I can see the comment by Kelly. So our question is, what were the timing of your surveys within the academic year? So the survey we conducted in 2020 was in June, so that was at the end of the academic year and just before the summer break. Also, we saw that, for example, in the e-health interventions that we offered to students, quite a few students were not as active when the summer break started because there was good weather, you could go outside. And the survey that we just conducted 2 weeks ago, it's like halfway during the academic year. So I would be interested to see if there's any differences in the prevalence, for example, when we would conduct our survey at the start of the academic year, which can be quite a stressful period, also for first-year students, for example. So we're also thinking of implementing an e-health intervention specifically for those for that group of students. And then with regards to the second question, is it reasonable to assume that your findings can be extrapolated across the general population? I think to a certain extent, yes. I think students are a specific group. They're young adults, emerging adults. There's a lot of different things coming together, and I think student life should be a very fun period in your life, but can also be a very challenging period. There's a lot of new things that come across, like living in a new city, making new friends, like searching new way through life. There's an increasing demand also with regards to social media. There's a lot of comparison going on. So I think it's a challenging period for a large group, but we do see that mental health did suffer a negative impact from the corona pandemic. So yeah, I think students, they have it extra challenging because they want to socialize, and but yeah, to a certain extent, I think they are extrapolated across the general population. Okay,
thank you very much. I see there's a question from Mirko about whether there's an opportunity for bachelor's students, and Kelly has replied that we're working on an idea to develop what in the UK we would call a module or a course or a learning opportunity, really, which brings together students, perhaps 2 students from 3 or 4 Aurora universities each, so students in teams of 6 to 8 to work together on a research project, perhaps a comparative project, to compare the COVID response, maybe in a particular field like in higher education or in healthcare for the elderly, or or a more general kind of policy level, and to produce a study jointly as a little research team, an international research team. So that's something we're exploring for next academic year to start in the autumn. Some Aurora universities will be participating, but maybe not all. If you wanted to do something informally, you could put your contact details in the chat so that any other of the participating students who might want to get in touch with you could get in touch with you. You could possibly do that, or we could, with your permission, circulate your contact details to other students who participated today. If you were looking just more informally to exchange ideas, I'm sure we can arrange something like that. But we do have to be careful about data and sharing, so we would have to do that sort of with people's permission. Now, there was another question from a new name, I think, which was Michael at 1651, which I think is probably best put to Paul in the first instance, which is about the efficacy of the vaccines. If they're about 70% effective, just I think, what does that mean exactly? And later on, he clarifies he meant some 30% chance to get infected. So he's
I mean, well, it's what it means is that if you've got 2 people, or actually, if you've got 100 people who have been vaccinated and 100 people who haven't been vaccinated, and they're put into the same circumstance where they're all exposed to infection, that would, in the 100 people without vaccine, would mean all of them got infected, which is, that's not going to happen. At most infection rates would be about 1/3, but let's assume that everybody gets infected. So 100 out of 100 people non-vaccinated get infected. With the 70% efficacy, you would have 30 out of the 100 people vaccinated would get a symptomatic infection. But again, I would stress that efficacy is around just symptomatic infection. The evidence suggests that it is much, much better at protecting against severe disease, pneumonia, and such like that would lead to need to be hospitalized. Does that?
Yeah, I fully agree. But can I add to that it doesn't mean that 70% is protected against infection in general. It's about the measurement is the outcome of the study is, do people develop symptoms, mild or severe, and not so much whether they acquire the virus.
Yeah, absolutely. And the efficacy of the is against depending on what the dosing regime was, either only about 3% or 50% in the Oxford vaccine. So there is good suggestion that it doesn't the Oxford vaccine doesn't stop you getting infected, but it does stop you or reduce the chance of you developing symptoms, and substantially reduces your chance of developing severe symptoms.
Okay, thank you very much. We're just down to the last couple of minutes now, so I think I need to draw proceedings to a close. My thinking was that COVID is such a multifaceted crisis. It raises questions of epidemiology, but also of economics, of public health strategy, of politics, and of social behaviour as well. So there's something in this for most academic disciplines, and I thought it would be great to harness the Aurora network to provide an opportunity for our students to get absorbed in some of the thinking around COVID and its implications. I'm really pleased with the level of engagement, and there have been some great questions. I'd like to say a big thank you to our 3 speakers who so generously gave of their time and put together their presentations especially for this audience. I'd also like to say a big thank you to Kelly, who's been a great help in organising the event. I never would have been able to do it on my own, so thanks very much, Kelly, for all of your help. For those of you who are going to do projects on COVID, best of luck with your studies, and thanks very much for being involved, and do keep safe. Thank you very much.